Hi, Dr. John Torres here, my Doc to Doc series, where every week I cover a topic. Up until now, it's usually been related to the pandemic, but as the pandemic's starting to get to a point where it's winding down a little bit, we're starting to broaden the subjects and do more health-related topics that affect you, your family, your loved ones, your community, and hopefully give you some information that you can walk away with, that you can help live a little better life, live a healthier life, and hopefully live a happier life as well. But I know one of the things that affects a lot of us on a daily basis, sometimes across the world, are headaches. We've all had headaches from time to time. Some people more so than others. Some people, it affects their lifestyle and their life more than others. But to help me drill down on this is Dr. Juliana VanderPluym. She's a pediatric neurologist at the Mayo Clinic Arizona. And Juliana, thanks for being here. But first, to also address one big thing you always talk about when you talk about this is you also treat adult patients.
I do. Yeah, I treat both.
Excellent. You're the expert here. And the reason we're talking about this is because a new study that just came out, and the study looked at the impact of headaches around the world. And what they did is they basically looked at a variety of other studies, and not just for adults, but even children down to the age of 5. And I thought this was very interesting. They found out that 52% of the global population is affected by what they call a headache disorder within a given year. So over half of us, and on any given day, they estimate 15% of the world's population has a headache. We're almost 8 billion people. That means around 1 billion people every day in this world have headaches. So do those numbers surprise you?
I mean, they don't surprise me because that's what I see every day, day in, day out. Every patient that I'm seeing has headache. I think a lot of people aren't talking about their headaches. And if we start talking about it more, they wouldn't be surprised. They would be surprised how many of their friends, colleagues, family members have headaches. It's just something that we're not talking about, unfortunately.
And one thing I've learned in the emergency room is a headache is not just a headache. There are a variety of different kinds of headaches, migraine, tension, rebound headaches, a variety of different ones. What are the main categories you put them into?
Sure. So we break it down into two big categories. We have what we call primary headache disorders and what we call secondary headache disorders. And so primary headache disorders are where the headache itself sort of is the problem, meaning that that person's nervous system is wired in a way that it generates the headache. So those are things like migraine, cluster headache, tension type headache. Then we have the secondary headache disorders. And those are the headaches where some other condition is either damaging or is irritating the nervous system and is causing headache as a symptom of that other condition. And so that can be things like, the common cold, that could be things like COVID, that can be things like a brain tumor. And I think people are always very worried about secondary headache disorders, but in reality, what we see most commonly are primary headache disorders. And we have to take them just as seriously because, as you said, they can really impact people's lives.
And like I mentioned when we started this, I'd like to give people information that they can use and they can walk away with and say, hey, I learned something today that can help me with my own life and my own health. What are the concerning signs that, because, oftentimes, again, if 15% of the world's population is having a headache every day, that doesn't mean 15% of the world's population needs to run to the emergency room. What are the warning signs where people need to get their headaches checked out?
Sure. So we actually have a mnemonic that we sort of use to help us remember all of the features that can be worrisome about a headache. So if you're someone who, never had headaches before, and then out of the blue, you start getting headaches, that is, something that we always want to be mindful about. Now, that might just mean it's the first time you get a migraine, but nevertheless, that is kind of something that we, perk up our ears a little bit. If you ever have headaches that start really, really suddenly, just like boom, like a 2x4 is hitting your head, we call those thunderclap headaches. And those are something that really worry us and, should warrant you getting checked out immediately. If you ever have headaches that develop in the setting of certain activities, so, if you are being sexually active, or if you are picking up something really heavy, or if you cough or sneeze and just suddenly this really severe headache starts, that's another reason that we would want people to get checked out. And then, of course, if you ever have any sort of neurological symptoms, so if you have a headache and then you also, suddenly can't see or can't move part of your body or can't feel part of your body, those would really be some of the main reasons to get checked out.
What's the mnemonic?
It's called Snoop 4. So it's pretty clever. And so the S stands for sort of systemic symptoms. So that would be like fevers, weight loss. The N stands for neurologic symptoms. The O stands for onset. So if you have headaches that start, when you're really young or when you're really old, kind of under 5 or over 50. And then the other O is also for onset, that being thunderclap. And then the different P's are the if it's precipitated by straining, if it's postural, so if it's worse when you're laying down or worse when you're upright. Papilledema means swelling at the back of the eye, and then also actually during pregnancy or after pregnancy, that can be reasons, and then progression as well. So if the headaches are getting worse and worse and worse over time.
Well, I love it, Snoop 4. And I know, being in an emergency room and having spent 20 plus years there, not much raises the eyebrows of emergency room staff. But when somebody comes in and they say those two different things you talk about, this headache, it felt like somebody hit me in the back of the head with a 2x4, or the other thing is, this is the worst headache I've ever had in my life. Those will raise our eyebrows and we'll go, okay, we need to pay a little more important attention to this to make sure that we don't let them sit there with anything dangerous that we need to take care of. Let's talk a little bit about the different headaches, particularly the two big ones that most people know about and suffer from, presumably, migraines and tension type headaches. What's the difference between those two?
Yeah, so when it comes to primary headache disorders, we distinguish between them based on the clinical features. And so what I mean by that is, where the headache is located, how long the headache is lasting for, how often you're getting the headache, what other symptoms you're having with the headache. In the general public, tension type headaches are more common, but what we see in clinic is more commonly going to be migraine, just because of the fact that migraines are generally more severe headaches. And so, to define a migraine, I think a lot of the time people think, okay, well, I have a friend who has migraine or a family member who has migraine, and that's what migraine looks like in them. And that's not what my headaches are like. So that means I don't have migraine. And that really isn't the case, because when we look at the criteria for migraine, you don't have to have every single feature for it to be a migraine headache. But some of the general features are that the headache usually lasts between about 4 to 72 hours. It often can be more on one side of the head, but actually in about 40% of people, it is more on both sides of the head. And in younger people, so in children, it actually is more likely to be a bilateral headache. The pain is usually moderate to severe in intensity, and it's often worse with physical activity. So when people have a migraine, they just want to be really still or want to kind of go lay down somewhere. The other thing is that people often have sensitivity to light or sound during a migraine. So they want to be in a dark, quiet place, or they may have nausea or vomiting. Now, they don't need to have every single one of those features. They just need to have, kind of a certain amount for a doctor to be able to diagnose you with migraine.
And then tension headache, what is that?
Yeah, so tension type headaches, they're interesting because when we look at the criteria, and we have a manual that's called the International Classification of Headache Disorders that kind of outlines all these criteria. Tension type headaches can go anywhere from lasting 30 minutes all the way to 7 days. So, huge range as far as how long they can last for. They're usually a kind of mild to moderate headache. They're usually on both sides of the head. They usually have more of a dull, achy quality, while migraines are more of a pulsing, throbbing sort of quality. And they don't generally have the associated sensitivity to light or sound or nausea or vomiting. And people can really usually continue their activities despite having a tension type headache.
Why is it called tension type? And what I usually tell my patients is it's not because of tension in your life, it's because of tension in your neck.
Yeah, so tension type headache, I think sometimes that name can be a little bit misleading. So yeah, it isn't just saying, oh, you've got stress, now you have a headache. And actually, even with tension type headache, some patients may or may not have muscular strain with it. So tension type headache, we do believe, is arising from the nervous system, not necessarily from musculoskeletal issues, but it often is more commonly associated with sort of musculoskeletal strain or pain, and people might have tender points or more tension through their neck, with that type of headache.
Going back to migraines here, one of the biggest complaints you get from people who do have migraine headaches is that friends, family, loved ones will often tell them it's just a headache. It's more than that, right?
It is completely more than that. And, we're really redefining migraine as not just a headache. disorder. You know, it is really, I think, patients feel that they're not validated when they're told it's just a headache, because when you see someone who has a migraine, and if you yourself ever unfortunately have the experience of having a migraine, there is so much more that is going on there, because we consider it in some ways kind of a sensory processing disorder, in the sense that our brain is processing the environment. It's processing what we see, what we smell, what we hear, how we perceive pain, how we perceive where we are in the environment, our perception of our digestion, which means, you know, things like nausea and vomiting can occur. And in migraine, the brain is almost on high alert. Everything is heightened. Pain, things that shouldn't normally be uncomfortable, like brushing your hair or pulling it back into a ponytail, that can become painful. Light that shouldn't normally be painful now is too bright. Sound that shouldn't be, you know, so loud is now, you know, uncomfortable. Smells can make people feel sick. And so it's just so much more than that. And I think that's where it's unfortunate, because, you know, it's dismissed by family members, it's dismissed by friends, and it's unfortunately sometimes even dismissed by healthcare providers that, you know, aren't listening or taking their patients seriously.
You know, at the beginning, I talked about that study. The reason we're having this talk is, you know, the 52% of the world's population in a given year has a headache. 15% estimated every day, you know, around the world have a headache anytime during the day. And of that, 7% of those are migraines. So they happen more frequently than I think most people think and most people realize.
Definitely. Yeah. I mean, when we look in the US, it's about 12% of the general population, and it's about 3 times more common in women than it is in men. It also occurs most commonly in kind of our most productive years, sort of between that age of 25 to 50, when people are building families, building careers. And so, you know, having a condition like migraine can really impact people's lives in a negative way.
Now, to put this in a big, you know, under a big umbrella, which is might be difficult to do, but there are treatments for all these types of headaches, correct?
Definitely. There are a lot of different treatments. And when we think about, you know, primary headache disorders and secondary headache disorders, for secondary headache disorders, we obviously want to address the underlying condition that is causing the headache, and then also address the pain from the headache itself. For primary headache disorders, I think it's important for patients to realize that we don't necessarily have cures. I can't cure someone's migraines. I can't cure someone's cluster headache or someone's tension type headache. Those are conditions that are sort of wired into their nervous system, and in some ways wired into their genes a little bit. But we do have lots of therapies that can be really effective. And when it comes to treatments, we break it down into what we call acute or rescue treatments and what we call preventive treatments. And so acute treatments are something that the person would take in the moment that they're having the headache to get relief. And then preventive treatments would be something that they would be taking if they're having frequent headaches, to try to reduce the frequency and the severity of the headaches. And there's lots of options in both of those categories.
And are there any generalities for headaches, regardless of which kind you had, any kind of lifestyle changes that would help prevent those or help slow them down at least?
Sure. So, you know, when it comes to lifestyle, it's funny because lifestyle things can actually be the hardest things for us to change. You know, sometimes it almost seems easier to take a pill than it is for us to exercise regularly, than it is for us to, you know, have good sleep habits, like not being on our phones and tablets right before we go to bed and keeping the bed just for sleeping, maintaining good hydration, eating healthy. And I know sometimes people ask, you know, is there like a migraine diet? We don't have a specific migraine diet, but we do recommend, you know, foods that are rich in omega-3s, because those have anti-inflammatory properties. And then stress management. I mean, at the end of the day, we cannot eliminate stress from our life. It is part of our lives as human beings, but we have to find ways that we can manage our stress. And some of those, you know, strategies, behavioral strategies, actually have some of the best evidence when it comes to migraine treatment. And so those are things that we do really encourage, you know, patients to try to do. But sometimes that just isn't enough, and we do need other interventions to help kind of boost people's migraine or headache thresholds.
You study migraine headaches. That's one of your specialties. And when you study migraine headaches, you're looking particularly at the interictal phase of migraines. Can you explain that?
Yeah. So The interictal phase, this again expands on that idea that migraine is more than just a headache disorder. So what we've discovered about migraine is that there's all these different phases to it. So the interictal phase is basically that phase between someone having the headache part of their migraines. And we have something that is called the prodrome or the premonitory phase. And then we have something called the postdrome, which a lot of my patients call their migraine hangover. And so the premonitory or the prodrome phase is basically when patients might start having these symptoms that sort of hint to them that a migraine is maybe coming on. And some of these can be really subtle, and people might sort of think maybe they relate to something else. So they might start yawning excessively. They might be getting a little bit irritable. They might start noticing their neck is a little bit tense. Light seems a bit brighter. Sound is a bit louder. And then sure enough, within about 24 hours or so, boom, that migraine is there. And then the postdrome is sort of this phase where they're kind of recovering from their migraine. They might still feel, sort of tired, have trouble concentrating, and, a little bit of nausea. The headache is gone, but they're not feeling quite themselves. And, if you put all of those phases together, that means that besides just having a headache, you might have a few days on one side of it and a few days on the other side where you're not feeling that great. And it can really, add up as far as the burden of migraine.
It's interesting because, thinking about it from, my experiences, it almost sounds like a post-ictal phase from seizure disorders where, something's happening in the brain physically, and then it takes a while to recover from that. And so is this kind of showing that something is happening physically in the brain with migraines and it takes a little bit to recover?
That is exactly it. And you know what? They've actually done imaging studies looking at activity in the brain in these different kind of times during the migraine. And they found that different parts of the brain light up. And for example, during that premonitory or that prodrome phase, they found that the hypothalamus, which is this little tiny part of our brain that sort of regulates all these things that are happening in the background, which we call homeostasis, kind of the balance in the body, that part of the brain becomes activated. And so it almost is like this trigger that's sort of setting off this imbalance in the body that we can pretty clearly link to some of these symptoms that people are describing, as far as, potentially cravings that they're having before migraines, as far as their energy levels, as far as their mood changes that they're experiencing. So we are, learning a lot by being able to map out these areas of the brain, depending on what kind of time in the migraine that we image.
And Juliana, unfortunately, I could talk to you for about 4 hours with this. We don't have that much time. But the last question I want to ask you, the last thing I want to talk about is I think it's a phenomenon that a lot of people don't understand or haven't even really heard of, and that's rebound headaches. Something that could be induced because of something they're doing. Could you talk about that a little bit?
Yeah, so rebound headaches, or the medical term that we currently use, which is medication overuse headache, is basically when the medications that we're using to try to relieve our headaches actually end up sort of changing our pain pathways and end up resulting in having more headaches. And so, it's unfortunate the medical term medication overuse because it almost seems to imply that this is the patient's fault when really that isn't the case. They're just trying to do their best to manage their symptoms. And unfortunately, the treatments that they're using become part of the problem. And this is a condition that can develop when people have frequent headaches and so are taking the medications frequently, but it takes a while for it to occur. So usually it's over at least 3 months that this can start to develop. The risk is different with different medications. So for example, with opioid medications or medicines that contain butalbital, those have the highest risk of medication overuse headache or rebound headache. Medications in the triptan family, those have sort of intermediate risk. And then medications in the anti-inflammatory family, or something called GPANs, those have lower risk, if not no risk. And so, it really does, it really is important for physicians to, be talking to patients about this because they're not going to know that the medicines they're taking could lead to this. Now, the other type of rebound headache that patients, I think, talk about is just when they take a pill and then the headache comes back again the next day. And that's not so much a rebound. That might just be that the medicine isn't working as well as it should be. And so you should be talking to your doctor to see if you should maybe be just getting a different medication to be using.
And Juliana, that's such brought up a great point. This is not the patient's fault for doing this. They're doing what they can to try and handle it. It's just the mechanisms behind how these things work. And unfortunately, sometimes, and I've seen this in the ER where they do get into the cycle of, the medicines causing rebound, which they take more medicines, which causes more rebound. And I think the biggest take home message I can give is, number one, a headache is not just a headache, but also number two, don't be hesitant to seek care if you need that care, because sometimes it's going to take help to get through these headaches. And like the study shows, half the world's population in a given year has a headache, 15% every day have headaches. So it's debilitating. And it's certainly, I appreciate you being there for us and helping give us some information, but also taking care of the patients you're taking care of. The one thing we didn't delve in, I definitely want to bring you back at some point for this, is you're a pediatric neurologist. And so, talking about children, because it's not just adults who get affected by headaches, but unfortunately, we don't have time to talk about that, but would love to in the near future. So please come back sometime.
Well, I'd love to. I love talking about headaches. So thank you for having me.
You bet. And again, this is Dr. Juliana VanderPluym. She's a pediatric neurologist at the Mayo Clinic, Arizona, and an expert who gave us a lot of information about headaches. Juliana, thank you very much. And again, appreciate you being here and hope you have a great rest of your week.
Thank you.